Hello. Now we are on to chapter 17, which is digestive system disorders. And I mean, digestion is really cool, right? I mean, obviously we get to eat things and then we have to digest it so that we can get all the energy that we need to make our body do crazy things like study for pathophysiology or all the other things. So you've learned a lot about the digestive system when you're in anatomy and physiology, right? So now we get to actually talk a little bit more about the digestion. But again, you learned about those processes before. So like what goes wrong to cause like diseases. So my cat Sophie is deciding to be very needy right now. So apparently she's going to be a star in this. So with the digestive system disorders, then we're going to start out with the structure and function of the upper GI tract, the liver, the pancreas, and then the lower GI tract. The importance of each of them, and the diseases that can occur with defects in each of those parts. Also, with the functions of digestion, well, we get to be able to eat our food and then process it, and either the food and or the fluids that we have, and we break them down into their units. So, for instance, like carbs, my favorite food group, right? Um, they're basically sugars, right? So we have to break them down to the singular glucose, and then we go through glycolysis to break down the glucose to pyruvate. It goes into citric acid cycle, blah, 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 right? We can break down fats through beta oxidation. We can break down proteins through protein deamination, right? So we all have to break them down into their constituent building blocks. And this is all controlled by enzymes. And the cool thing about enzymes is they're named for what they do, right? So, if it's glyceraldehyde 3 dehydrogenase, well, it's going to be working because it ends in ACE, so it tells you that it's the enzyme on glutaraldehyde 3 hydrogen, right? So it just kind of they tell you what they're there for, and so that is one cool thing about science. Since they're rooted in Greek words, you can kind of figure out what they're for by their names most of the time. And also, the main function of digestion is that we're going to absorb the necessary components that our body needs. And these are going to help to facilitate membrane transport mechanisms. And most of the digestion is actually going to be occurring in the small intestine. So, looking at the anatomy of the digestive system, this is, early on in the thing, but basically, you start with your mouth, then you go through, and you end up with all the waste that we're not using going out of your body through the anal canal by poop, right? So this is figure 17.1 in your book. And so I'll point out the events here that are happening, but then again, you can see the anatomy. But in the mouth, the events are going to be chewing food, adding saliva, water, and we start to digest our sugars or those carbohydrates in our mouth. And then the esophagus, that function that is important for that is going to be swallowing. The stomach itself is going to be where we mix and dilute the chyme, which is like the masticated, partially chewed, started to be digested stuff that we swallow. We also have gastric secretions that are going to be digesting the protein, adding the intrinsic factors that we need for further digestion. And also, this is a very acidic environment. Like the pH of the stomach is right around like pH 2, right? Between 1 and 2 because of the stomach acid, which is right up there, right down there, I guess, on the pH scale of hydrochloric acid. So that's why when you vomit, it burns because it's acid coming back up. Then down here in the small intestine, this is where we have bile that's going to be released from the gallbladder, right? And this is going to emulsify, which is a fancy word for like breaking it up into really, really small particulate matter. So it's going to be the pancreatic secretions, the bile emulsifies the fat. We have pancreatic secretions. We also have intestinal secretions that are going to be digesting the fat, protein, and the carbohydrates. And this is where we also have the absorption of nutrients that is going to be the main component of it. And then the colon, the main component of the colon is going to be absorbing water and electrolytes back into the body so that we keep, again, that osmotic level that we want. And then, of course, the rectum is going to be where we're going to store it, the excess waste at this point until we can defecate. So with looking at structures, these are the structure and their function. This is started on page 428. And so your gut wall has mucosa, submucosa, a circular smooth muscle layer, etc. Well, the mucosa is going to be an epithelial layer, and this includes the mucus producing cells. Okay, and then we have the submucosa, and this is going to be of I'm looking for something in the book, sorry, the connective tissue, including blood vessels, nerves, lymphatics, and secretory glands. Then we also have our a circular smooth muscle layer, and this is where it's going to help to propel things through the longitudinal smooth muscle layer. And then we also have the serosa, which is the visceral peritoneum. Looking specifically at the upper GI system, this is started on page 430, and this consists of the oral cavity, which is where food and fluid are taken into the body through the mouth. And this is the initial phase of what's going on, and we go into these each in detail, so I'm not going to detail them right here because the next slide is literally about the oral cavity. The esophagus, which is like the long pipe to get it down into the stomach, is where we do like the chyme is going to be like squished all around and started to really be digested. So the oral cavity, this is the initial phase of the mechanical breakdown of food, and mastication is just a fancy word for chewing. And this is what our teeth do, right? And so thankfully, when we're born and growing up, we have a full set of teeth and they do a good job. But if you think of some elderly people or some people that don't have very good dental care, when they lose teeth, they can't chew a steak, for instance, anymore, right? They can't chew peanuts, so they have to have like the soft foods because they lose that skill of mastication. This also starts the initial chemical digestion in the whole system, and this is through the work of salivary amylase. And so again, remember enzymes are kind of named for what they do, salivary, saliva, right? And so this is the, I'm thinking of a big juicy berry. Actually, I have something in the Instapot right now. And it smells really good, right? So it's making my mouth salivate because it's like anticipating that I'm going to eat something here in a little bit. But the salivary amylase, that's going to start that chemical breakdown of those sugars, those carbs in our mouth. And then it forms a bolus. Okay. And so that's just like a wad, right? So if you, next time that you eat something, I really want you to pay attention to it. And so, take that big bite of a steak or a burger or whatever, you chew it until it's kind of like the consistency of mashed potatoes, right? In this little wad. And then that's when you swallow it. We then have the pharynx, and this is where we're going to swallow, and this is called deglutination as well. And that's where it's going to start its travels, right? And so this is, my cat is being crazy. This is a picture of the oral cavity, and this is on page 430. And so this just, again, details the anatomy of where the lips, the gums, your different types of teeth, the uvula, which is that little dangly thing in the back of your throat, palatine tonsils, if you have had tonsillectomies, these are what the ones they usually take out, your tongue, the sublingual ducts, and also like the opening of the submandibular gland here is there too. So specifically talking about the esophagus, this is closed except for during swallowing, and it is a skeletal muscle at the superior end, and then it turns and transitions into smooth muscle. And so with the activity of swallowing, the soft palate is going to be pulled forward. The vocal cords are approximated, right? The epiglottis covers that larynx so that we don't go down the wrong pipe, right? You can't breathe when you're swallowing. That wad of food or a bolus is seized, it's grabbed, right, by the constricted pharynx, and then that bolus of food moves down into the esophagus. So take a second here, and I want you just to swallow and just kind of feel all these things happening in your mouth, right? So go, and you can feel the muscles, and you can feel like spit, water, whatever, lemonade in this case, and coffee going down. Right, so it's kind of cool. So as we're going through this is usually if we were in class in person, I would be handing out snacks and having you guys eat so that you can really pay attention to what's going on. Then the stomach, this is an expansible muscular sac, and so that just means it can expand and contract, right? And it acts as a reservoir for fluid and food. This has three smooth muscle layers, and there's a constant mixing and turning of food. So it's just kind of so, if you eat something and your stomach's like bubbling or gurgling, it's doing that on the normal. It's just maybe you're a little bit more gassy in there and you can feel it, or your stomach's really not liking something and it's trying to get it out, right? But you can just kind of think of it as like, I don't know, a waterbed going back and forth, right? And this is where we have the initial digestion of proteins that's going to be taking place, and this is through the action of pepsin, and this is formed by the combination of pepsinogen and hydrochloric acid. We also produce an intrinsic factor, and this is we need this because it's essential for the absorption of vitamin B12 in the ileum part of your digestive system. This is also where we formulate chyme. So that bolus, which is just that wad of like pre-chewed or chewed food that goes into your stomach, is now going to mix with the stomach contents, and it's going to kind of create this sludge in a way, and that's what we call chyme. And we also have the absorption of small and lipid-soluble molecules that are occurring here in the stomach. In the liver, this is the metabolic factory of the body, and this receives blood from the hepatic portal vein, and this is really responsible for transporting nutrients from the intestine down to the liver. The hepatic portal vein is. The hepatocytes are going to store those nutrients, and these also play a role in carbohydrate, protein, and fat metabolism or breakdown. We also have the production of plasma proteins and clotting factors that occurs here in the liver. And the breakdown of old and damaged erythrocytes also occurs in the liver, as well as bile production. So as you can see, liver is really, really important. So that's why we can't go without liver, right? We have liver transplants if we need them. The pancreas is considered an exocrine organ, and this is arranged in lobules. So it's just kind of little lobes, like kind of stuck together in a way. And this is going to secrete digestive enzymes and electrolytes, including trypsin, chymotrypsin, carboxyl peptidase, ribonuclease, pancreatic amylase, and also bicarb ions, which is going to help to neutralize the pH and keep it where it needs to go, right? And the pancreatic duct is going to join the bile duct and enter into the duodenum. Moving on to the lower GI, this is going to be on page 432. This is the small intestine, and it has the duodenum, the jejunum, and the ileum. We have villi and microvilli, and these are basically folds. And villi are the big kind of like it would be kind of like the Grand Canyon, right? It's a big one, where the microvilli are like little tiny folds on top of the big fold. And this is really important because the main function of this is that it increases surface area. Okay, if we increase surface area, then those enzymes, those digestive enzymes, can get to the food particulates easier, or not the food, the membrane surface easier, and then it can absorb it more because we have more surface there, so that we can absorb it quicker and faster. And so because of this is the major site for absorption of nutrients. We also have a lacteal, which is the lymphatic vessel, and this is the site production of mucus, enterokinases, peptidases, nucleosides, sidases, lipases, sucrases, maltases, lactases, and cholecystokinin, which is a hormone. So here is a summary of the major digestive enzymes and their actions. And so you can see there's salivary amylase that's excreted from the parotid gland, and then this is going to be splitting the starch and glycogen into the disaccharides, which then go further down into like monosaccharides, right? So this is a great little summary. This would be great maybe for flashcards, and this is on page 430. Again, it's table 7.1. The large intestine has Peyer's patches, and these are lymphatic tissues, and it also has its own resident flora, and these are going to help to break down certain food molecules, as well as this is where vitamin K is going to be made by bacteria. We also have fluid and electrolyte reabsorption and the formation of solid feces, and this is what's going to allow for mass movements because it kind of just compacts and gathers in there. My cat's going crazy because she can't sit in my lap. Parasympathetic. So, okay. So moving on to neural and hormonal controls. Um, These are on page 433, and we have the parasympathetic nervous system and the sympathetic nervous system. So this will be abbreviated as PNS, which is the parasympathetic, right? And then the other one is SNS, which is the sympathetic nervous system. So with the parasympathetic nervous system, this is primarily controlled through the vagus nerve, which is cranial nerve 10. And this is going to increase the motility as well as increase secretions in the stomach, right? In the intestines. The sympathetic nervous system is going to be stimulated by factors such as fear and anger, and this is going to inhibit GI um, activity, and then it's also going to cause vasoconstriction. And this is also going to cause reduced secretions and regeneration of epithelial cells. So this is kind of like, when you're like running away from a lion that's attacking you, when you're really hungry, you don't really care about digesting food at that minute. You're caring about other things. And so because of this, it's going to cause the reduced secretion and just kind of rebuilding of, problem like structure there so that when you're ready to, digest again, you can. So here is a summary of the major controls of the digestive tract and their effects. And so this is table 17.2, and this is on page 434. So again, this would be great for flashcards. The gastrin, gastric cells is the source. The stimulus is food in the stomach. Effect is that it's going to increase the gastric secretion and the movement and promotes gastric emptying, right? So I know I'm distracted by my cat, but she's being hysterical. Okay, neuronal and hormonal controls continued. We also have the facial cranial nerve 7, 5, 6, 7, yep, and the glossopharyngeal, which is cranial nerve 9 nerves, and these are going to maintain the continuous flow of saliva or spit in your mouth. You also have distension and stretching of the stomach. So, like on Thanksgiving Day, Christmas Day, when you eat so much and you like really stretch out the stomach, this is going to activate from the PNS. And then this is going to increase peristalsis, which is just the rhythmic pulsing or movement of the food through the system, and also gastric secretion. And then the stomach is going to empty within 2 to 6 hours after a meal. And when the food is in the intestine, this has a stimulation of intestinal activity, and this is from the enterogastric reflex, and this is going to inhibit the gastric emptying. Hormonal controls are the main ones are like these guys, so gastrin, histamine, secretin, and cholecystokinin. So gastrin is going to be secreted by those mucosal cells in the stomach in response to the distension or the stretching of the stomach or the partially digested substances. Increased gastric motility is going to relax the pyloric and ileocecal sphincters, and this is also going to promote stomach emptying. Histamine is going to increase the secretion of the hydrochloric acid. Secretin is going to decrease the gastric secretions, and cholecystokinin is going to inhibit gastric emptying and stimulating the contraction of the gallbladder. Specifically talking about where things are digested and absorbed, carbohydrates, the digestion starts in the mouth. And this is followed by digestion in the small intestine. The proteins is where we start digesting it in the stomach, and this continues in the small intestine. And then our lipids, these are going to be emulsified or broken down by bile prior to the actual chemical breakdown. So we like break down the fat particles into smaller little droplets. And the action of enzymes are going to form monoglycerides and free fatty acids. And this is also where you have that formation of the chylomicrons that's going to occur. Our fat-soluble vitamins, you'll learn this in nursing school, is ADEK, is how a lot of students remember it. So A, D, E, and K, ADEK, are going to be your fat-soluble vitamins. And these are absorbed with fats because they're not water-soluble. They have to be absorbed by fats because it's like oil and water don't mix, right? So if you put a fat in water, it's not going to it's not going to be absorbed. And so you have to absorb fat vitamins with fat-soluble things. You have your water-soluble vitamins, and these are your vitamins B and C, and these are going to diffuse into your blood. You also have electrolytes, and these are going to be absorbed by active transport or diffusion. And our drugs are primarily absorbed in the intestine, and this occurs through various transport mechanisms. And some, for instance, aspirin, are absorbed in the stomach. So that's why, I mean, first of all, you shouldn't, I always do this, so don't do what I do. You shouldn't take meds on an empty stomach, especially aspirin, because it can cause, like, ulcers and things, because, you know, there's no buffer or coating there to help like not have the med directly have like irritation on your stomach, etc. And also some aspirin is absorbed in the stomach. So like when you're, not that you guys are going on to develop pharmaceutical interventions, etc., but this all goes into play. If it's an orally taken medication, they have to make sure that it will be absorbed in the proper area. And then beyond that, it has to be able to potentially pass the blood-brain barrier if it needs to go into the neural system. Water, this is absorbed primarily by osmosis. And about 700 milliliters of water is secreted into the digestive tract each day. And about 2,300 milliliters is ingested by food and fluids, and only about 50 to 200 milliliter leaves the body in fecal material. Severe vomiting or diarrhea will interrupt this mechanism and therefore potentially dehydrate you and therefore affect the fluid and electrolyte balance of the body. So 700 milliliters, I'm sure you guys know this, but to put it into kind of I don't know, like a picture, a 2 liter of pop is 2,000 milliliters, right? And so we get just over about 2 liters of water a day through food and fluid, but only about 3/4 of 1 liter. So that'd be, I don't know, what about a third-ish? I don't know, I'm not doing the math in my head, of a 2 liter is going to be secreted into the digestive tract each day. And then only 50 to 200 milliliter leaves the body in your poop. So that would be like this much of a 2 liter, right? I mean, it's very, very small. So moving on to digestive system disorders. And so this starts on page 435. And they talk about like bulimia and stuff like that. So I'm actually really diarrhea, constipation, right? So I'm glad that they kind of touch on. I really like this book because they touch on touchy subjects. So some of the basic diagnostic tests that are available can be radiography, where contrast medium may be used. I've actually had this done to me before, where I've had a barium contrast to see if I had GI issues. Ultrasound, and this may show unusual masses. You can also do CT scans, MRI scans, and the CT or MRI may also use those radioactive tracers, and they can be used for liver and pancreatic abnormality diagnoses. You can also do a fiber optic endoscopy in the upper GI, and this can also be piggybacked with biopsy, so that if we do have a problem, that we can take a biopsy while you're, in the right position, right? You could have a sigmoidoscopy or a colonoscopy, and this is where you have a biopsy and you remove polyps that, if they're there, this can be where it happens. You can also have laboratory analysis of stool specimens where you check for infection, parasites, and eggs of parasites, right? Bleeding, tumors, and malabsorption. You can also have blood tests such as liver function, pancreatic function, and cancer markers. So most of the common therapies and prevention honestly come from dietary modifications. And so if you have celiac disease and you have a gluten intolerance, well, don't eat gluten. So two of my nieces have this, and so they have to stay away from gluten. The other one has a dairy intolerance, so they have to stay away from it or else they pay, right? Also, reduce your intake of alcohol and coffee, because those are mostly very acidic, and that can disrupt and make your stomach not feel so good. And also increase your amount of fiber and fluid intake. So, fiber doesn't need to necessarily be by eating Fiber One bars or, drinking Metamucil. It can be from, vegetables have a ton of fiber in it. So kale, and broccoli, just a lot of the things that make you fart, right? No, fiber is undigestible, and so that's why it's kind of like a brush through your GI system. And also make sure that you drink enough fluid so that your stool isn't super compact and painful to pass. Also, stress reduction techniques, which I know is kind of laughable in 2021 because we're still in the middle of a pandemic, right? And because stress impairs immune function and tissue healing. And then you can also have medication. This is where there's a variety of medications that are available to help, treat any of these disorders. Some of these drugs would be antacids to relieve pylorus, antiemetics to relieve vomiting, laxatives or enemas to treat constipation, and antidiarrheals, which are going to reduce that pushing feeling, that peristalsis, and also relieve cramps. Sulfa drugs, right? These are anti-inflammatories and antibacterials, and these can be used for acute episodes of inflammatory bowel disease. Clarithromycin and azithromycin, and these are going to be effective at, over Helicobacter pylori or H. pylori infection, and usually this is going to be combined with a proton pump inhibitor. Then you also have sucralfate, and this is a coating agent. And this is used to enhance gastric mucosal barriers against the irritants such as NSAIDs, right? Those non-steroidal anti-inflammatory drugs. And so, like this is like your Advils and stuff like that. You see how they have like that orange coating or a coating on it? That's this, so that it can help to, to not irritate your stomach. You can also have anticholinergic drugs, and these are going to reduce the parasympathetic nervous system activity. And then you can also reduce secretions and motility. You also have histamine 2 antagonists, and these are useful for gastric reflux. You also have proton pump inhibitors, and these can reduce gastric secretions. So here is examples of drugs that are used in digestive system disorders. And again, you know how I love my tables, right? And so this is on page 440 of your book. This is table 17.3. Right, and so it's the classification, examples, and then also the different actions. So moving on to upper GI tract disorders, you can have disorders of the oral cavity, dysphagia, esophageal cancer, hiatal hernias, gastroesophageal reflux disease, gastritis, peptic ulcers, gastric ulcers, dumping syndromes, as well as pyloric stenosis. So there can be a lot of things that can go wrong. When we're talking about the gastroesophageal reflux disease, this is where we have a periodic reflux of the gastral contents into the distal esophagus, and this can cause erosion and inflammation in that throat area. And this is often seen in conjunction with the hiatal hernia. The severity of it depends on the competence of the lower esophageal sphincter, and we can also have delayed gastric emptying that can be a factor, therefore causing things to back up. So how to kind of try to avoid these is going to be avoid using caffeine, fatty and spicy foods, alcohol, smoking, as well as certain drugs. Also, use of medication may reduce the reflux and inflammation. Moving on to peptic ulcers, including the gastric and duodenal ulcers. Most of these are caused by those Helicobacter pylori infections, the H. pylori, and these usually occur in the proximal duodenum, and these are called duodenal ulcers. These can also be found in the antrum of the stomach, and these are your gastric ulcers. The development of these ulcers begins with the breakdown of the mucosal barrier, and so because of that, we have decreased mucosal defense. And remember, the stomach acid and stuff is really, really acidic. And so if you don't have that mucosal layer, then you're basically having acid right on tissue, and that's what's causing these things, right? So these are more common in gastric ulcer developments. And then also because of that increased acid secretion, this is a predominant factor in duodenal ulcers. So looking at this is a peptic ulcer, right? And these are common locations of those peptic ulcers that you can see. And I'm trying to find where in your book. Here we are. This is going to be figure 17.14 on page 452. And so this is just showing you the typical locations of the peptic ulcer and the gastric carcinoma, right? So this is the anatomy, And then the little stars are your gastric ulcers, carcinomas or cancers, right? Esophageal ulcer, duodenal. So it's based on the location of where they are in the stomach. This is an example of a bleeding ulcer on a gastric mucosa, and this is where the red like clotty thing looks, and this is on page 453. And so you can see a bleeding ulcer obviously has blood, and then you can see the ulceration, which is that disruption and the irritation of that skin. Not skin, but the tissue. Due to damage in the mucosal barrier, this is going to predispose those to development of ulcers, and it's also associated with inadequate blood supply, and this would be caused by vasoconstriction from stress, smoking, shock, circulatory impairment in older adults, scar tissue, and anemia. This is also going to interfere with rapid regeneration of the epithelial cells. This is caused by excessive glucocorticoid secretion or medication. Ulcerogenic substances can also break down that mucus layer, for instance, aspirin, NSAIDs, and alcohol, so that's why don't do it on an empty stomach. You can also have atrophy of the gastric mucosa, which can cause chronic gastritis. The increased acid pepsin secretions can cause increased gastrin secretion. Vagal stimulation is increased sensitivity to the vagal stimuli. Increased number of acid pepsin secretory cells in the stomach, which would be due to a genetic anomaly. Also, increased stimulation of acid pepsin secretion, and these can be stimulated by alcohol, caffeine, and certain foods. Also, it can interfere with normal feedback mechanisms, and this can cause rapid gastric emptying. So basically, things don't sit in your stomach; they just come in the mouth and out the other side, right? Complications of the peptic ulcer can be hemorrhage, which can be caused by the erosion of blood vessels. This is a common complication, and this may be the first sign of a peptic ulcer. You can also have perforation. This is where the ulcer erodes completely through the wall, and then that chyme, remember, which is like that digestive soup, can then enter into the peritoneal cavity, and this can result in chemical peritonitis. Or you can also have an obstruction that occurs, and this may result later because of the formation of scar tissue. So talking about the gastric and duodenal ulcers, the signs and symptoms are that you have the epigastric burning or the localized pain from that acid coming back up, right? And then this is usually following the stomach emptying. You also have diagnostic tests that you can use, and this would be like the fiber optic endoscopy, the barium X-ray, or the endoscopic biopsy. Then you can have, I'm trying to find this in your book, the treatment, which would be the combination of antimicrobial and proton pump inhibitors to eliminate the Helicobacter pylori that caused it, and then also reduce the factors that exacerbated it or made it worse. Right? So what about stress ulcers? Well, these are associated with severe trauma or systemic problems, including burns and head injuries. Also, this can be from hemorrhaging or sepsis, right? And it can have a rapid onset, and then you can also have multiple ulcers. These are usually gastric ulcers that may form within hours of the event that caused it to be the onset. The first indicator, for instance, could be hemorrhage and severe pain. Right. So, yeah, this is peptic ulcers are on 451. Gastric cancer, dumping syndrome. Yeah. Okay. So when we're talking about gallbladder disorders, this is on page 456. So you have cholelithasis, and this would be the formation of gallstones. And this is where solid material, which is called caliculi, form in the bile. You can have cholecystitis, and this is where you have the inflammation of the gallbladder and the cystic duct. So again, look for those root words, right? And so cystic, right? And that's what I'm saying. Cholangitis would be the inflammation usually related to the infection of the bile ducts. And then you have cholelithiasis. That's one. Choleodosin, whatever. And this is the obstruction of the biliary tract by gallstones. Sometimes you know how your like tongue gets twisted on things. Usually I know how to pronounce these things, but apparently my bond does not want to pronounce that one. All right, so bile ducts and pancreas with the possible locations of gallstones. This is shown in figure 17.18 on page 456. And so this is pointing out the biliary ducts and the pancreas with the possible locations of those gallstones. And so gallstone, I mean, you have a tiny little pebble in a very small little tube, and then it can cause blockages, and they can pile up, and they're very, very painful, right? Moving on to gallbladder disorders, this is on page 456. Gallstones can vary in size and shape. They can form in the bile ducts, gallbladder, or the cystic duct, and they may consist of cholesterol or bile pigment, and these have mixed contents with the calcium salts. These can be caused by small stones, and these may be silent and excreted in the bile. You might not really even know, where the larger stones can obstruct the flow in the bile, and the cystic and common bile ducts cause severe pain, which is often referred to as subscapular in the subscapular area. This is a picture of some pretty wicked gallstones. This is figure 17.19 on page 456, and it's a resected gallbladder, so it was taken out, containing mixed gallstones. So those are some pretty well-developed ones, and that would be very, very painful. Continuing on with gallbladder disorders, the risk factors for gallstones are women are women are twice as likely to develop stones. You have high cholesterol content in the bile because you have a high cholesterol intake. These can also be caused by obesity, multiparity, use of oral contraceptives or estrogen supplements, the hemolytic anemia, alcoholic cirrhosis, as well as biliary tract infections. Obstruction of a duct by a large calculi. This would be sudden severe waves of pain, which can cause radiating pain. You can have the nausea and vomiting, which is usually present. The pain is going to continue, and jaundice can develop. Bile can back up into the liver and the blood, and then the risk of the ruptured gallbladder, if the obstruction persists, is high. The pain can decrease if the stone moves into the duodenum. And then surgical intervention, like we saw in the previous slide, a couple slides ago, of that big picture, may be necessary. And sometimes we can remove them by laparoscopic surgery. And then because you won't be having your gallbladder, a low-fat diet would be necessary following the surgery. My mom and my sister actually have both had their gallbladders taken out, and so they have to be very careful, and they can't eat fried foods anymore because they can't digest it anymore. So they get sick if it goes right through them. Right? Jaundice is talked about on page 457. You have your prehepatic jaundice, and this is the result of excessive destruction of red blood cells. And this is characteristic of those hemolytic anemias or transfusion reactions. You can have intrahepatic jaundice, and this occurs with disease or damage to those hepatocytes. And it was hepatitis or cirrhosis, hepatitis. I'm making up words today. You guys like this? Usually I don't know what's wrong with my brain. I got a lot of sleep last night too. So hepatitis or cirrhosis. You can also have post-therapeutic jaundice, and this is caused by obstruction of bile flow into the gallbladder or the duodenum, and this would be from a tumor or cholelithiasis. Here is a table of types of different jaundices, right? And this is figure 17.21 on page 460. And so again, this, you know how much I love tables. And so this is detailing the process. And then if it's prehepatic or hemolytic jaundice, intrahepatic jaundice, or posthepatic or obstructive jaundice from like gallstones. So these would be caused by hemolytic anemia. This one would be from hepatitis, and this one would be from gallstones. So then you can see we have unconjugated bilirubin in the blood. It goes to the liver cells, and you have conjugated bilirubin, and it goes out to fecal material. But this is a great little summary of the different types and what's actually going on in them. So bilirubin measurement in jaundice. So this is direct or conjugated bilirubin can be measured in the blood, and the total bilirubin is measured in the blood. Total bilirubin minus the direct bilirubin is the amount of indirect or unconjugated bilirubin. With jaundice, the type of jaundice can be indicated by the increase in serum bilirubin levels and also changes in your poop, right, in your stool. Prehepatic jaundice, this is where we have unconjugated bilirubin levels are elevated. Intrahepatic jaundice is where we have both unconjugated and conjugated bilirubin levels that can be elevated. And then you also have posthepatic jaundice, and this is where you have increased conjugated bilirubin levels, and the light colored stool is caused by the absence of bile. Looking at the structure of a liver lobule, you can see that, a lobule that there's like smaller little, pocket kind of things. And so it's kind of cool to see that. And so you can see that you have a lot of innervation, right? So you have the central and intralobular veins, you have the sinusoids, the plates of the hepatic cells, etc., right? And then this is how it's all intercalated, and then it's connected to the hepatic duct, and it's going to and from the hepatic portal veins and arteries, right? And this is very similar to the figure of 17.20 in your book on page 459. Okay, so it's just showing the liver lobules, showing the portal areas and the central veins, and this is just a cross section of this one right here of the liver lobule. So talking about things that can go wrong. So hepatitis is a big one, and this is this is inflammation of the liver, and it can be from alcoholism, and this can cause fatty liver. It can be idiopathic, which is a fatty liver. It can have it can be from a viral hepatitis, which would be a local infections. It can be from infections that occur elsewhere in the body, and some examples would be infectious mononucleosis, so mono, or amoebiasis. And also this can be due from chemical or drug toxicity. With viral hepatitis, this is talked about on page 458. I'm going to get my jacket here. It's cold. The cellular injury results in inflammation and necrosis in the liver, and the degree of inflammation may vary. The liver is edematous and tender, and you can have causative viruses that can cause viral hepatitis. So you can have Hep A, Hep B, Hep C, Hep C, D, and Hep E. They talk about each of them in your book, and we're going to talk about each of them. There are a couple of them here too. So hepatitis A, this is abbreviated HAV. This is caused from a small RNA virus. It's infectious hepatitis, and it's transmitted from the fecal-oral route in areas of inadequate sanitation or hygiene. It's often from contaminated water or shellfish. Also, sexual transmission has occurred during anal intercourse. It is acute but self-limiting infection. There's no carrier or chronic state. The fecal shredding of the virus occurs before the onset of the signs. And then there is a vaccine available for travelers, food care workers, as well as healthcare workers. Hep B is going to be a partially double-stranded DNA virus, where over 50% of the HIV positive patients are also positive for Hep B. 50% of the patients are asymptomatic but contagious because they are carriers, and chronic inflammation can also occur. Transmission is primarily by infected blood. Sexual transmission has been noted. So this one is the one that you potentially could get from tattoos, like dirty tattoo needles, body piercings, drug addicts, right? This is the one where they get when they share needles, etc. There is a vaccine available now, and this is routinely given to children. And like the Hep B vaccination has only come out within the last, 5-10 years. So that's pretty cool. Hep C, this is single-stranded RNA virus. This is the most common transmitted by blood transfusions, and it may exist in a carrier state. And about 50% of patients enter into the chronic state, and you have an increased risk of hepatocellular carcinoma, and this can be treated with interferon injections. Hep D is also called Delta virus, and this is an incomplete RNA virus, and this requires Hep B to replicate and produce active infections. Hep D infection increases the severity of Hep B infection, and this one is also transmitted by blood, which makes sense because they're kind of piggybacking. Hepatitis E is a single-stranded RNA virus, and this is transmitted by oral fecal route, and there is no chronic carrier state. So there are signs and symptoms, and so we have a pre-esoteric stage, and this is where you have a fatigue and malaise, anorexia and nausea, general muscle aching, etc. You have the esoteric stage, and this is where we have the onset of jaundice. The stools are going to be light in color, the urine becomes darker, the liver is tender and enlarged, and you have a mild aching pain. You have the post-esoteric stage, and this is the recovery stage, and this is where you have the reduction in signs, and this is where this can persist for weeks. Okay, this weakness does. So looking at a nice little table flow chart of the course of hepatitis B infection. This is figure 17.23 in your book on page 462, and so this is just the exposure of the hepatitis B virus. So this is HBV or serum hepatitis, and this leads to the incubation period, which is the asymptomatic period, and this averages between 6 and 8 weeks. And then you can go to the asymptomatic carrier state, or you can show the acute infection, which is going to be 4 to 12 weeks long. You have the pre-esoteric stage, which is just going to be malaise, fever, and joint pain. You have the esoteric stage with jaundice, and this can lead to fulfillment infection, which can lead to severe necrosis and liver failure, and that can lead to death. So this is not very good. Or you can have, with the esoteric jaundice, you can lead to recovery, or you can lead to chronic infection, which can cause long-term mild infections, cirrhosis or liver failure, or hepatic cancer. The only body defense is the formation of antibodies by vaccination. We also have supportive measures such as rest, diets high in protein, carbs, and vitamins. You can also have chronic hepatitis that can be treated with interferons, and this can decrease their viral replication. This is effective in only 30 to 40% of individuals, and this drug combination, which is a slow-acting interferon plus antiviral drug, is more effective. Moving on to cirrhosis of the liver, right? This is page 463. This is the progressive destruction of the liver, and causes a lot of the times we hear about this one from a chronic alcohol use, right? So alcoholic liver disease. Also medication can cause it, but the ones that we hear about is mostly from excessive alcohol use over time. So this is, we have biliary cirrhosis, and this is associated with immune disorders. You have post-necrotic cirrhosis, and this is linked with chronic hepatitis or long-term exposure to toxic materials. And you also have metabolic cirrhosis or reasons, and this is usually caused by genetic metabolism storage disorders. This is caused by extensive diffuse fibrosis, and since, remember, fibroids are not very pliable, and it's kind of like, in a way, scar tissue, in a way. So with that, it's going to interfere with blood supply, and because of that, the bile can back up. And also, since we're interfering with the blood supply, you can have, things try to reroute to stay alive. And so you can have that loss of the organization of those different lobes. So the loss of the lobular organization. You can also have degenerative changes that can be asymptomatic until the disease is very well advanced. A liver biopsy and serologic tests to determine the cause and extent of damage are required. This is figure 17.24 in your book on page 463, and this is showing you the cirrhosis of the liver due to hepatitis C infection. And so it says nodules with regenerated hepatocytes may be present but are not necessarily functional because of the vascular network, and the biliary ducts are distorted. And so even if the primary cause is removed, further damage is likely because fibroids interfere with the blood supply to liver tissue and the bile may back up, leading to ongoing inflammation and damage. So initially the liver is enlarged, but it becomes small and shrunken as the fibrosis proceeds. In many cases, the degenerative changes are asymptomatic until the disease is well advanced. So specifically talking about the alcohol one, because again, this is probably one of the more common ones that we are going to be seeing. The initial stage is from fatty liver, and this is causes an enlargement of the liver, and this is asymptomatic, and it's also reversible with reduced alcohol intake. Okay. The second stage is the alcoholic hepatitis, and this is where we have the inflammation and cell necrosis. We also have the fibrous tissue formation, and this is an irreversible change. The third stage is end-stage cirrhosis, and this is where that fibrotic tissue replaces normal tissue, and this then causes normal function to kind of cease, right? So it stops because, again, fibrotic tissue, the fibroids, it's going to kind of be like scar tissue. It's just not going to be able to do its job. So functional losses that occur with cirrhosis, we have decreased removal and conjugation of the bilirubin, decreased production of bile. We're going to have impaired digestion and absorption of nutrients. We also have decreased production of blood clotting factors and impaired glucose and glycogen metabolism. The impaired conversion of the ammonia to urea also occurs. So all of these things are very important in the body. You also have decreased inactivation of hormones and drugs, and the drug doses must be carefully monitored to avoid toxicity because you're kind of giving more than what you normally would because you're not being able to absorb them, right? You also have decreased removal of toxic substances, and so your body can, go toxic and have toxicity a lot easier. You also have reduction of the bile entering into the intestine, and this is going to impair the digestion and absorption. You can have a backup of bile in the liver, and this can lead to obstructive jaundice. You can also have a blockage of the blood flow through the liver, and this can lead to portal hypertension. And also you have congestion in the spleen, and this increases hemolysis. So again, break it down to the root word. Lysis is to break apart, hemo is blood. So this can lead to breaking down your blood cells. You can also have inadequate storage of iron and vitamin B12. You can have congestion in the intestinal walls and the stomach, impairing the digestion and absorption. You can have development of the esophageal varices, and this can lead to hemorrhaging. You can also have development of ascites, and this is an accumulation of fluid in the peritoneal cavity. And I mean, I actually had a friend, well, I met her in the hospital, and unfortunately she didn't make it. No, but ouch, I just banged my knee. But she had ascites, right? And so she looked like, I mean, if it was possible, she looked like she was 11 months pregnant. I mean, she was this little tiny thing and had a belly out to there, and it was just all fluid. It was insane. But this is going to cause abdominal distension as well as pressure. So this is a graph of the development of ascites with cirrhosis. And so this is detailing that you have the liver damage, and then you can have blocked lymphatics, portal hypertension, decreased synthesis of bilirubin, or albumin, sorry, and decreased blood volume plus reduced inactivation of aldosterone and ADH. So this is a fun little summary table that, nope, that I'm trying super hard to find the, let me pause you guys for a second. Okay, this is on page 466, and this is the development of ascites with cirrhosis. And so, again, you can have the liver damage that's up here in purple, and that can lead to the blocked lymphatics, which leads to increased fluid in the peritoneal cavity, therefore leading to ascites. You can have portal hypertension, and this can lead to increased hydrostatic pressure in the portal circulation, which leads to the fluid shifts out of the portal circulation into the peritoneal cavity, therefore ascites. You can have decreased synthesis of albumin, causing decreased plasma osmotic pressure, and this can again lead to those fluid shifts and ascites. You can also have decreased blood volume plus the reduced inactivation of aldosterone and ADH, and this can lead to increased serum aldosterone and ADH and increased sodium and water retention, therefore leading to that fluid shift and ascites. Ascites is going to cause upward pressure on the diaphragm, and this can impair your respiration. It can cause increased risk of peritonitis, and so inflammation, irritation of the peritoneal cavity. And it can also lead to impaired digestion and absorption. Talking about cirrhosis, this is the initial manifestations are often mild and or vague, okay? And this is fatigue and anorexia, weight loss, anemia, diarrhea. Dull aching pain may be present in the upper right abdominal quadrant. All right, I'm trying to find your book. This is a long chapter. Okay, this is on page 463. With advanced cirrhosis, this can cause ascites in the peripheral edema. This can cause increased bruising, esophageal varices, and these may rupture, leading to hemorrhage and circulatory shock. This can also cause jaundice and encephalopathy. So, with effects of advanced cirrhosis, you can see this on page 467, and this is figure 17.28. You can have the encephalopathy, which can lead to confusion and lethargy. You can have skin lesions, which can lead to spider nervi or pertussis, esophageal varices. You can have a nodular liver from the fibrosis, the ascites, which is that can cause the distended abdominal veins, the GI hemorrhage, rectal varices, as well as testicular atrophy and impotence. You can have increased bruising as well as edema in the extremities. It can cause jaundice, which is the overall yellowing of the body. Pulmonary problems can be edema and infections. You can have gynecomastia in males, which is the development of breasts in males. You can have a splenomegaly. It can cause anorexia, nausea, impaired digestion and absorption, as well as weight loss and fatigue. And you can also have amenorrhea in females, which is a lack of a period or a monthly menstrual cycle. So how do we treat cirrhosis? Well, we're going to avoid alcohol or a specific cause. You can also be supportive or you can also have supportive or symptomatic treatment. You can have dietary restrictions. You want to try to balance those serum electrolytes. You can have paracenteses. You can have antibiotics to reduce the intestinal flora. There is emergency treatment if esophageal varices rupture, and you can also potentially lead to a liver transplant. So here is, it looks like table 17.4. This is common manifestations of your liver disease. And so this is a great little summary. And this is on page 464. And then, it's going to summarize your signs and symptoms on the left, as well as the pathophysiology is why it happens on the right. The lower GI tract disorders, these would be like celiac disease, chronic inflammatory bowel disease, irritable bowel syndrome, appendicitis, diverticular disease, colorectal cancer, internal obstruction, as well as peritonitis. Talking a little bit about the chronic obstructive or chronic inflammatory bowel disease. This is talked about on page 469, and this is like Crohn's disease and ulcerative colitis, are chronic irritable inflammatory bowel diseases, or IBDs. My dad had Crohn's, and so I know quite a bit about this, right? Causes of this are unknown. There is a genetic factor that appears to be involved, but they're not even specifically, they don't even exactly know which genes. They have a couple that they suspect, but they haven't figured it out yet. Crohn's disease usually presents itself during adolescence, so late teens, early 20s. Ulcerative colitis, this is presenting itself in your 20s and 30s. And then there are many similarities between Crohn's and ulcerative colitis. And I know there's no S, but Crohn disease versus Crohn's. I always call it Crohn's. IBD, this is, again, your table 17.7. This is on page 470. It's going to tell you the region that's affected in Crohn's versus ulcerative colitis. And, distribution of the lesions, characteristic stool, etc. Crohn's may affect any area of the digestive tract, and usually it does target the small intestine, but it can do any part of it. Inflammation occurs in characteristic distribution. You have these skip lesions, and these are affected areas that are separated by areas of normal tissue. It does also progressive inflammation and fibroids that may cause obstructed areas. The picture looks crooked, but it's not. You also have progressive inflammation and fibrosis, and this may cause obstructed areas. You can also have damaged walls, impairing the processing and absorption of food, as well as inflammation that can stimulate intestinal motility. It causes interference with digestion and absorption. You can have hypoproteinemia, so low protein, avitaminosis, you're not absorbing your vitamins, malnutrition because the food that you put in is just kind of going right back out, and possibly steroidemia. Other complications can be that adhesions develop between loops, and fistulas may also develop. If it's caught in children, it can cause delayed growth and sexual maturation because they're not getting the nutrients that they need. Like my dad used to have to have like Ensure drinks to make sure, like when he was having a flare up, to make sure that he was at least getting what he needed because food just didn't stay with him. You can also have glucocorticoids that are used in the treatment of Crohn's. So this is an overall picture of Crohn's. This is on page 471, and it's figure 17.33. This is showing those skip lesions, and these are distributed, a distribution of affected segments alternating with normal segments of the bowel. Okay. Then this is showing the changes in the intestinal wall, where you have a narrow lumen, which is that opening that can lead to obstruction. You can have rigid, thick walls, which is that fibrosis. You can have the normal, thin, flexible walls. Then you can also have inflammation here and ulcers in the mucosa. And then down here, this can lead to the fistula, or an abnormal opening between two structures. So they kind of fuse together and make a new little opening that's not supposed to be there. And this would be on the left here, a thick wall, and then where they're joining, and then this can cause inflammation and the erosion of a wall. This also is showing you an actual picture, right? And this still is figure 17.33. And this is just showing those lesions, the inflammation, the narrowing, and all of the things that we just talked about. Moving on to ulcerative colitis. This is on page 472. This is where the inflammation starts in the rectum and it progresses through the colon. The mucosa and submucosa are inflamed. The tissue destruction interferes with the absorption of fluid and electrolytes in the colon. You have severe acute episodes. For instance, toxic megacolon may develop. And you have marked diarrhea with up to 12 stools per day. And this contains blood and mucus, and it's accompanied by cramping pain. So this is figure 17.23 in your book on page 472. And this is showing a normal colon on the left. And then this is a colon affected by the ulcerative colitis. So you can see all the irritation and the difference in the texture of that colon. Talking about diverticular disease, this is causing the development of diverticula, and this is discussed on page 475 of your book. So at the diverticulum, there is an outpouring or a herniation of the mucosa that occurs through the muscular layer of the colon. Diverticulitis, diverticulosis is an asymptomatic diverticular disease where diverticulitis is the inflammation of the diverticula. Say that 20 times fast, guys. I dare you. Diverticular disease, again, is going to form at gaps between the muscle layers. It's a congenital weakness of the wall that can be a factor of it. The weaker areas of that are going to bulge when the pressure increases. In many cases, are asymptomatic. The diverticulitis stasis of the material in the diverticuli is going to lead to the inflammation and infection, which is going to cause cramping, tenderness, nausea, and vomiting. And also there can be a slight fever and elevated white blood cell count. You can have the treatment of diverticulitis, which could be antimicrobial drugs, as well as dietary modifications to prevent stasis. This is a picture of diverticulitis. This is figure 17.37 in your book on page 476. And so A over here on the left shows diverticulitis of the sigmoid colon. And over here is just a low power, so zoomed out, a micrograph of a diverticulum of the colon showing the protrusion of the mucosa and the submucosa through the cell wall. Colorectal cancer starts to be discussed on page 476. Most malignancies develop from adenoiditis polyps, and the early diagnosis of this is essential. The cancer occurs primarily in persons that are older than 50 years of age. Risk factors include familial multiple polyopsis, long-term ulcerative colitis, genetic factors, as well as environmental factors such as diet low in fiber. Initial signs are dependent largely on the location of where this growth is. Some general signs can be changes in bowel habits where you're alternating between diarrhea and constipation, bleeding, fatigue, weight loss, and anemia. Treatment would be surgical removal with radiation and or chemotherapy. This is figure 17.39 in your book on page 478. And these are the common signs and symptoms of colorectal cancer. So you have, if you have a problem in the ascending colon, you have a liquid stool where you have occult blood in the stool or melanemia or ulceration. You have anemia, fatigue, late palpable mass, right? For the transverse colon, you have a semi-scoid stool, semi-solid stool. It can have anemia, and the occult blood is found in the stool. You also have changes in your blood habits. And the descending colon, you have a solid stool, and this would be constipation, discomfort or obstruction from the obstruction, abdominal fullness and distension, as well as red or dark blood in the stool. Where if you have the colorectal cancer more in the rectal area, this is going to have the formation of a solid stool with abdominal discomfort and cramps. You have a ribbon or a pellet stool with incomplete emptying and red blood on the surface of the stool. This is a picture of colorectal cancer that you can see, and this is figure 17.38 in your book on page 477, and this is the circumferential malignant growth or the cancer that's going to be obstructing the flow of fecal material, causing proximal dilation of the colon. So here you can see the colon's bigger, it's distended and dilated upstream to the obstruction. The obstruction is right here. And then this structure is due to this circumventricular growth, right? And so you can see it kind of backs up and causes a distension of that colon. Talking about intestinal obstruction, this is discussed on page 479. This is a lack of movement of intestinal contents through the intestine. This is more common in the small intestine. You have mechanical obstruction. This can result from tumors, adhesions, hernias, and other tangible obstructions. This can be functional or adynamic obstructions, and these can result from impairment of a peristalsis, that pulsating movement through your GI system. This can be potentially from a spinal cord injury or a paralytic ileus that was caused by toxins or an electrolyte imbalance. Um, so here are some pictures of some different causes of the internal obstructions. This is on page 480 in your book. And so this one is an inguinal hernia, which you can see is going to be distended here, causing a problem. B here is a volvulus, where the blood vessels are compressed and basically the intestine twists itself in a knot. In horses, this is colic, right? Over here in C, this is intrasuspicion, and this is where you have the telescoping of the ileum inside the adjacent section of the colon, right? And then the blood vessels are drawn in between the layers and compressed. Down here you have a tumor, which is going to be compressing, right? And then here you have diverticulitis, and this is where the colon's going to be narrowed by scar tissue, and the diverticulum is going to be filled with feces, and it's going to cause inflammation as well. Again, that's figure 17.41 in your book on page 480. Gases and fluids accumulate proximal upstream to the blockage, and this causes a distension or a stretching of the intestine. Increasingly strong contractions of the proximal intestine can occur in effort to move the contents along, and then the pressure increases in the lumen, and so more secretions enter the intestine, and then that causes further compression of the vessels and the veins in the wall, and then the intestinal wall becomes edematous or swollen, right? And then this causes a prevention of absorption. Intestinal distension is going to lead to the persistent vomiting that we often see with this, and that causes even more additional fluid and electrolyte loss, and hypovolemia can result because of this. Also, the intestinal wall can become ischemic and necrotic, and if the obstruction is not removed, gangrene can happen. With ischemia and necrosis, this can cause decreased innervation and a stopping or cessation of the peristalsis, that contractile movement. And then the paralytic ileus can occur if it is not a cause to begin with. The obstruction is going to promote rapid reproduction of the intestinal bacteria, and some produce endotoxins. The affected wall becomes necrotic and more permeable, and also the bacteria and toxins, therefore, because of the permeability increase, can leak into that peritoneal cavity, which is called peritonitis. It's causing an inflammation of the peritoneal cavity, or into the blood, which can cause bacteremia or septicemia, both not too very good. And then this perforation, right, of the necrotic segment can occur, and then this can cause generalized peritonitis and septic shock to occur. The functional obstructions or paralytic ileus can occur from abdominal surgery, following the surgery, spinal shock following spinal cord injuries, inflammation related to a severe ischemia, pancreatitis, peritonitis, infection of the abdominal cavity, hypokalemia, mesenteric thrombosis, and toxemia. Mechanical obstruction can occur from adhesions that twist or constrict the intestines, also hernias, structures that are caused by scar tissue, masses such as tumors or foreign bodies, intussusception, volvulus, Hirschsprung disease, as well as gradual obstruction from chronic inflammatory conditions. Mechanical obstruction of small intestines include severe colicky, abdominal pain, intermittent bowel sounds can also be heard. You can have paralytic ileus, and this is where the pain is steady and the bowel sounds decrease or are absent. Vomiting and abdominal distension, this occurs quickly with the obstruction of the small intestine. The vomiting is recurrent, eventually with the bile stain content. And then obstruction of the small intestine is a medical emergency. The intestinal obstruction, again, of the large intestine is going to develop slowly, often with mild signs such as constipation, mild abdominal pain, followed by abdominal distension, anorexia, vomiting, and more severe pain. Treatment, such as the treatment of the underlying cause, fluids and electrolyte replacement, as well as surgery and antimicrobial therapy. And the final slide is the effects of intestinal obstruction. This is figure 17.42 on page 481. And this is showing the site of obstruction is going to cause increased fluid and gas, leading to a distension or like blowing out of your stomach. The distension then is going to cause increased peristalsis to force the contents past that obstruction, and this can lead to that colicky pain. It can also lead to severe vomiting from distension, and the pain can lead to dehydration and electrolyte imbalance. And this can lead to increased pressure on the wall, which is going to cause even more fluid to enter into the intestine. And then because of this, the decreased blood pressure and the hypovolemic shock as a third spacing fluid shock occurs into the intestine, and it continues. And then down here we have continued pressure on the intestinal wall, which is going to cause edema and ischemia, or wall and decreased peristalsis. And then we also have prolonged ischemia that's going to cause increased permeability and necrosis of the wall, intestinal bacteria and toxins that can leak into blood, and also peritoneal cavity, which is peritonitis. All right. We'll see you guys in class. Have a great rest of your day. Bye-bye.